Great. So with that, I think we'll get started. We want to welcome everyone to the third Thursday speaker series. Tonight, we are so excited to be focused on community engagement and team science, advancing intervention research. This will be our last speaker series of the 2021-2022 year. And so we're going out with a bang, focusing on the broader team science, and drawing on affinity research groups from across the BU-BMC community. So with that, I'm Linda Sprague-Martinez. I co-direct the Community Engagement Core, and I'm going to hand it over to my co-director, Tracy Battaglia, who's going to lead this evening's discussion.
Thank you, Linda. Good evening, everyone. It's a pleasure to be here. Very exciting for us to close out our longitudinal speaker series with this discussion. Team science and community engagement are so intricately intertwined. It's really fitting for us to sort of have this discussion. I want to acknowledge and thank all of you who are with us tonight. We know that it's after hours. It's the night before a long holiday weekend in honor of Juneteenth. Some of you may have off tomorrow. Others of you may have off on Monday. And I also just want to acknowledge for those sports fans, Dima just reminded me that the Celtics game is tonight. So we're all gearing up for a lot of excitement for the next few days. I'm going to ask Dima to advance the slide. My name is Tracy Battaglia. For those of you who don't know me, I am in the section of General Internal Medicine in the Department of Medicine at Boston University and Boston Medical Center. And I get to co-direct the community engagement program for the BU Clinical Translational Science Institute with my colleague, Linda Sprague-Martinez. And so I'm going to start by framing some of this evening's discussion. We have three esteemed colleagues from across the institution who are doing team science, and we're going to engage in a conversation with them. It's going to be an interactive session, so we invite you to, as you have questions, please place them in the chat. If you want to raise your hand and ask a question, we also welcome that. I'm going to start by providing some framing for the evening, and then I'm going to ask our panelists to present some of their work to us and engage in a couple of predefined questions, and then open it up to the larger group. So our learning objectives for this evening are to explore how the ARC mechanism, which is the Affinity Research Centers, is advancing community engaged team science. We also want to help others develop strategies of identifying partners across the university and our surrounding communities. And we want to hear about strategies for engaging communities in the design of intervention studies. Next slide. So I'm going to just ground us in sort of talking a little bit about what the ARCS mechanism is. And then just frame for us sort of how we're thinking and defining community engagement. Next slide. So Dr. Katia Ravid could be here. She sends her regards. She provided me a couple of slides. I'm not going to do them justice as she would, but for those of you who are not familiar with this program, Team Science through Affinity Research Collaborative, sorry, I got the C wrong, in the Evans Center for Interdisciplinary Research. This program was initiated about 7 years ago under the leadership of Dr. Ravid and Dr. Barbara Kulke. And the purpose of these affinity research collaboratives, or ARCs, were really to spark team science in the spirit of channeling discoveries to advance translational science. And so as you can see here in the slide, the purpose of the ARC mechanism was to expand our educational mission around research and translational science, develop new research areas to the university, help develop cross-department and cross-campus collaborations with other institutes and biotech. And then of course, all of this in the spirit of channeling discoveries across the translational research spectrum. You can see from the metrics on the slide, it has been a wildly successful program. In the past 7 years, the ARC members have published over 500 peer-reviewed publications. They've funded 231 grants. They started their work sparked 2 new educational programs, and several new disciplines have been developed, as you'll see in the next slide. So this is a list of the 2022 ARC programs. 2 of those programs highlighted in orange are here with us tonight to tell us about their experiences. But you can see there's a wide variety of topics with a lot of multidisciplinary partners. Tonight, we're going to hear about the multidisciplinary program to identify predictors of efficacy and resistance to cancer checkpoint inhibition from Dr. Matt Kulke. And we also have the co-directors of the ME Health with Dr. Borrelli and Dr. Quintiliani. You can see from this this chart here that there's representation of faculty across campus from all the schools on the medical campus, the Charles River campus, and from Boston Medical Center, as well as the VA and other external partners. Next slide. So now that we have some foundational understanding of the ARC mechanism around team science, let's talk for a minute about what we mean when we talk about community engagement. So community engaged research is not a research method. It's really an approach that can be employed across all types of research methods. It's designed to catalyze action and advance justice and health equity research. Next slide. Some of you who've joined us in the past have heard us talk about core competencies of investigators who are doing community engaged work. And so they're listed for you here. And they include things like having perceived value of CE and how it can advance science, introspection and openness, having knowledge of the community characteristics that you're working with, having an appreciation for all different stakeholders and their lived experiences, preparing for collaborative decision-making, collaborative planning, effective communication across all the stakeholders, equitable distribution of resources and credit, and of course, not hovering in and hovering out with sustaining long-term partnerships with stakeholders. Next slide. This is my last slide before I open it up to our panel. This is just the continuum of community engagement to acknowledge that there are all different forms of community engagement, and they differ in terms of the integration of community members in the process. And so you can see on the left side of the slide that, you know, the least stakeholder influence is just an informational sort of component where we're simply informing stakeholders and we keep them informed, but they're not necessarily consulting on the project, involved in the project, collaborating on the project, or even sort of directing the project. And so we can all aspire to be on the right side of this slide, but we want to acknowledge and celebrate anyone who's doing anything along this continuum. Next slide. All right, with that, I'm going to introduce our speakers to you very briefly, and then I'm going to turn it over to them so that they can take it away. So Dr. Belinda Borrelli is professor and director of the Center for Behavioral Science Research at BU School of Dental Medicine. Dr. Matt Kulke is chief of hematology oncology and co-director of the BU BMC Cancer Center. And Dr. Lisa Quintiliani is associate professor of community health sciences at the BU School of Public Health. So we're very fortunate to have the different expertise of our members here today. So I'm going to ask Matt to get us started. I know he has some slides to describe to us and explain to us the ARC, his Affinity Research Collaborative and its sort of scientific content before we dive into talking about sort of the building of the multidisciplinary team. So Matt, I don't know if you want to share your slides or if Dima has them for you. There they are.
Yep, here we go. So first, thank you very much for inviting me. So our project has a long and complicated title. We've tried to simplify it, but in essence, what we're really trying to do is figure out why immunotherapy works in some people and doesn't work so well in others, and why it stops working over time. So if we go to the next slide, here we go. So I guess just to start and maybe set the stage, immunotherapy has really transformed much of cancer treatment. It's a new paradigm, and it really hinges on ways to make our own immune systems attack cancer, activate our immune systems, and then have that attack the cancer and hopefully shrink it, and ideally make it go away. There are a number of challenges with that. One is that it doesn't work forever. Our cancers or our bodies still figure out ways to get around it. The other really tricky part about it is that it's actually so new that we don't fully understand why and how it works. And one of the key things is that unlike other cancer treatments like traditional chemotherapy, which directly attack the cancer, these are treatments that really rely on our own immune systems to work. And if you take that a step further, that also means that things that affect our immune systems can impact how well these cancer treatments work. And we know that a bunch of different things can affect our immune systems. That can include our diets, perhaps, ways that we metabolize different proteins or different things that we eat. We also know, and this is one of the really most fascinating things, is that the microbiome, so the various different bacteria that live in our bodies, they live in our mouth, in our noses, in our intestines, can fairly dramatically impact how well immunotherapy works. How that it works, we don't know, but we know it happens. And finally, other things that are circulating in our blood, extracellular vesicles that are called exosomes that can be released by either the cancer or by normal tissues, can have an impact on how well our immune systems work. And these in turn, we also know can be impacted by environmental factors, by comorbidities, things like diabetes and obesity. So I've been talking a lot about these environmental factors. Here's the other big issue. In the clinical trials of immunotherapy that have been done, less than 5% of the participants are from underrepresented groups. So the data we have is extremely limited in that sense. And we felt that we have a really unique opportunity to address some of these very fundamental questions in a much broader way across a much more diverse patient population. And that was really the fundamental reason we wanted to look at some of these questions. So if we go to the next slide, we do have a wonderful multidisciplinary team here. I am working on more on the clinical side, leading a clinical team, what we call a translational research core. And we are working with some of the phenomenal scientists here at BMC and at BU. David Scher helping us look at metabolism, Evan Johnson helping us look at the microbiome, and Gerald Dennis helping us look at exosomes. And then also working with the BU Charles River campus with the metabolomics and chemistry team to help us look at some of the metabolites, and are coordinated all by a project manager, Kiana Madaviani. So again, a wonderful, real team here that is looking at the various different questions that we have. In the next slide, just to sort of illustrate how we are doing this, a very, very key component is, of course, the patients. And this study relies on patient samples, relies on patients understanding, being interested in what we're doing and participating in the research. We are using a prospective biobank. We're actually quite happy that we've already consented over 200 patients to the biobank. They reflect not only a diversity of different cancers that are being treated with immunotherapy, but also the wonderful diversity of the patients that we have here at BMC. Our consent rates say in some sense are quite encouraging at about 65%. So it is, I think, very clear that our patients really are interested and do want to participate in research, which is wonderful. Our next slide shows that when patients do consent to participate in this study, it's not a trivial thing. We're collecting a lot of different samples, blood collections at different times along their treatment, as well as microbiome collections, asking people to bring in stool samples, get nasal swabs, which are sometimes a little bit uncomfortable. So it is a really big deal. But I think it's a really important question, and we are incredibly grateful to all the patients that are participating and helping us answer these questions. So I will stop there, and perhaps a perfect segue to talk about community engagement, because quite honestly, we have not directly addressed it. So this might be a good opportunity.
That's great. Well, I appreciate that presentation because I think I actually understood what you're doing, even though it's very complex and way above my pay grade. So I appreciate the really careful sort of explanation. It's clear the problem that you're trying to address is complex, and you identified, the multi-layers of complexity and sort of, overcoming sort of these treatment challenges, which makes it clear that you need multiple disciplines involved. But could you just speak for a minute about how you built that really impressive team to come together to do this work?
I think we were thinking about the different questions and all the different components that can impact how well immunotherapy works, and then in many ways just went out and talked to people and tried to figure out where's the expertise who can help us answer some of these questions. Some of these questions, if not a lot of the questions, were actually, or at least the specifics, driven by the people that we're working with, because those are their areas of expertise. So it's really a balance from that standpoint.
Great. Thank you, Dr. Kulke. I'm going to hand it off to Dr. Borrelli and Dr. Quintiliani to tell us about the ME Health ARC. Did I get it right?
Yes, it's the Mobile and Electronic Health ARC. Can you see my slides?
Yes, we can.
So this is this year's group. It's the Mobile and Electronic Health ARC. Some people call it the ME ARC, but it's really the Mobile and Electronic Health ARC. So ME ARC sounds like narcissistic or something. Anyway, I'm the director and principal investigator. I founded it in 2016 with Devin Mann. He had left the institution, and Lisa and Tibor joined as co-directors. And this year we have two new core members, Swati Karan and Rebecca Mashuris, and we are from 4 different schools and 2 different campuses and 5 different departments. And we have a new initiative this year that we're working on, digital health inequities, which I'll talk about in a second. So our group is interested in all different kinds of mobile and electronic health platforms. And some of these platforms are really interesting to study in terms of intervention and survey research, because there's little or no difference in prevalence by income, race, and ethnicity or education in several of these. And others, there's more of a digital divide. So the mission of our ARC is to conduct state-of-the-art research and training in mobile and electronic health to improve health across a lifespan, with an emphasis on underserved and vulnerable populations. And like you were saying, it's to foster this transdisciplinary collaboration amongst people who maybe normally wouldn't work together. All of our projects have this unifying theme, like people are passionately interested about like hard to reach, hard to treat populations. How do you use mobile health for health behavior change and for enhanced health outcomes? So this is how we're organized. Well, this is a more general slide. So far we've had 7 pilot projects that's been funded. and well more than 11 now. I think it's like 18 affiliated projects. So you can see in the left panel, we kind of have these like cross-cutting cores or steering committee that's, kind of involved in all these different areas that you would need to build a mobile health platform. And we also have 153 BU member affiliates across the institution, many resources for BU members, external advisory board, and a set of postdoc and junior faculty mentees. Sorry about that. So the 7 ARC funded projects that we have run the gamut from, virtual reality to apps, web-based intervention, social media, text messaging, other kinds of connected devices. We have close collaborations with the electronic Framingham Heart Study and the general Framingham Heart Study, as well as other areas as well. And the intervention content we focus on is smoking, diet, physical activity, opioid use, alcohol, and many others. So here are some of the current projects that are ongoing, just to give you some examples. One is the PI is Dan Fulford on the Charles River campus, and he's at Sargent, and he is trying to motivate smokers with schizophrenia to quit smoking. And I could talk a little bit later about how he's involving the community in the redesign of it. It's an app that I developed, and he's redesigning it for people with schizophrenia. We have another project that's focused, that was conducted at BMC, focused on mobile health to minimize opioid use and pain. And our current project is a digital health disparities initiative. And what we're looking at is how to decrease the digital divide. How can stakeholders and developers co-design and co-develop with the population to make digital health platforms accessible for all. And so that's a project that we're working on this year. And our activities, we do an annual symposium every year. And this year we did a joint symposium with the Hariri Institute. So that really spawned even more collaborations between our MEARC and the Hariri Institute. I should also say the MEARC has collaborated with another ARC, and that resulted in a center grant. So maybe we can talk about that a little while. We've had monthly seminars, and we do have a website. And this just shows you the transdisciplinariness of our ARC. The first wheel is investigator steering committee and our advisory board and mentees by school, and our seminar speakers by school. So I think that's it. Stop sharing. Lisa, do you have anything to add?
No, I think that was a great run through. Thanks.
So thank you for that. I didn't realize your ARC's been in existence for 6 years. Yeah.
We are a graduated ARC. So I guess we're considered a program now. So, you do the pre-ARC phase where you have to prove your mettle that you are an ARC and you're coming together and you have good research ideas. And then we had our ARC phase, which was 3 years, and now we're sort of a graduated ARC. But I don't remember having a graduation party or anything.
Well, congratulations on that progression. I'd like to drill into that a little bit more and hear from you about how you built the team. You mentioned in one slide that there's 153 members of your ARC at this point. And so can you talk about the work that you did to sort of create the team and sort of how it has evolved over time?
So the members are those who come to our seminars, who might email us for help or consultation. Then there's sort of like the core leadership team, which is sort of like changed over the years, and our steering committee as well. And that's kind of fluid depending on what projects we're doing. So in the beginning, we had a lot of sort of like retreats with different investigators around mobile and electronic health. We also initiated several pilot projects and got people together for those. Our annual symposium and our monthly seminars, I think, have really stimulated collaboration. Lisa, what else do you think?
I think the other thing we thought about at the beginning was what are the different components an investigator might need when they were thinking about designing a mobile or electronic health intervention. So those things might be like a health literacy expert, a community engagement expert, a technology expert, and then trying to see who's doing that research at BU and seeing if they'd like to be a part.
Can you talk a little bit more about how you found your partners? So if other researchers wanted to do this, it sounds like you start by identifying the problem needed. And then what? Do you go to BU profiles and look people up? Do you go knocking on doors? You network with your colleagues?
I think all of the above, like Matt said, it's like pounding the pavement, it's going to events, it's networking, it's looking up who's doing what at BU. It's also, what also really helped? A while ago, Gloria Waters asked us to do research on TAP. So that was really good. It exposed us to, a really wide audience. Our yearly symposium has 85 people in attendance, 200, and it's just open at BU. We have a networking event at that as well. I think our seminars have stimulated. They used to be in person, now they're via Zoom. That stimulated a lot of people working together. And then part of it is like people emailing us and saying, hey, do you know anyone who does this? Or how can I liaison with an industry rep, person who does, builds app? Or so a lot of it is like this kind of consulting that we all help with for people in the BU community to meet other people.
I'm going to remind our participants to please, if you have questions, put them in the chat. I have a series of questions to take this group through, but we also welcome your questions. So can you talk a little bit more, both, all of you, sort of, this is just a general question around, how your teams work together to come up with your priority research questions? Like, what's that process look like? I'm thinking about sort of the CE principles of sort of, co-development, sharing, effective communication, appreciating the expertise of the others, because there's like very different sort of expertise in these groups.
I'm happy to start. We have pretty much like the classic lab meeting, if you will. We have our research group meets weekly, and what we've been doing with the ARC is having the other ARC members, the members of the other labs that we're working with, come in and join our meeting, and we present work together and share it in that way. So I guess I would say we follow pretty much the classic model from that standpoint.
I mean, ours has been organized around like, funding different pilot projects and using similar methods across those projects for community engagement. So for example, doing mixed methods work, quantitative and qualitative data collection to help design the intervention content and structure, and basically having co-designing and co-developing the mobile solutions with the target population. And so these similar methods and measures are like across all of the different projects, and even across like the projects that we're affiliated with, like the electronic Framingham Heart Study, and I know Lisa's doing some work with the VA as well. So all of that sort of like comes together for, Lisa mentioned all the steering cores that we have, and all of those are kind of like running across the different projects as well. Lisa, do you have anything to add?
Just in terms, I think some of your later questions, Tracy, will get into how exactly we engage with our community members to get some of the, consulting and informing measures on that metric you presented earlier. So we can chat about that when it comes up.
Great. Okay. So let's talk about community engagement and what is, I mean, I presented sort of a little bit of a framework around community engagement, but maybe you can sort of just share what your perspectives are within your own arcs of what community engagement is. Like, what does it mean? And who is your community?
Is it okay if I start off, or would someone else like to? Okay, so it might be one of the projects that I'm heavily involved with right now, which is related to the ARC, as it is a digital health project, takes place in public housing developments. So I was going to share some of my experiences in how we design these research questions. So thinking about your continuum that you presented, these were research questions that I came with. Like I had the topic in mind, but in terms of how I consulted with the community, it was a matter of engaging with a longstanding community advisory board that has been in place between public housing and BU and the Boston Housing Authority and the Boston Public Health Commission, attending those meetings, getting to know the board, presenting my ideas and getting feedback on them. And then once funding is secured, after multiple years, once funding is secured, it's a matter of showing them the plans for the intervention, getting feedback from them in terms of how to design the different things. And then throughout the project, getting a sense of how to do assessment, recruitment, all that sort of stuff, how to interpret results.
So it sounds like your community engagement is happening at the level of the research projects. And you use some of the competency language that we shared earlier, and in terms of sort of co-developing and co-creating together, which is really fabulous. And it puts you really far into the spectrum. Can you talk about community representation in your ARC and sort of in its membership? Is there any level of community involvement at that level? And it's okay if it's no, it's just, it sounds like most of the community involvement is happening at the level of the projects, which is fabulous.
What do you mean community involvement in the ARC? Oh,
you said there's like 150. Yeah, there's 153 members. Are any of them community members? Or are they all sort of part of the research academic?
Oh, no, those are all like BU faculty. We're serving the BU community, but the individual projects, you're right, like do employ advisory boards, extensive, advisory boards. Yeah.
Mm-hmm.
Can I also give a shout out to Rebecca Loeb, who spoke at one of our MEARC seminars,
of course,
and did such a fantastic job and really, stimulated a lot of thinking on the part of our 153 BU affiliated members. So thank you, Rebecca.
Yes, thanks.
It looks like there's a question in the chat from Carla Dumas. Do the ARCs reach out, engage graduate, postdoc students from BU or other institutions in their research?
Yes, we have a number of them that I showed on my slide. They've been undergraduates, graduate students, postdocs, and junior faculty, early career.
Yeah, I would say we do as well. And in fact, I think in all of the labs that are involved in the ARC, there are a number of postdocs and grad students that are working on it.
That's great. So Matt, I didn't give you an opportunity to share. I mean, your ARC is much newer. And in your, in your presentation, you talked about, the reason this ARC is necessary is there's essentially no representation of our diverse patient population in this kind of research. And that is really ultimately the goal of your ARC. and sort of inclusivity sort of was the word I think you used. And so I wonder if your team has thought about what CE might look like, or might be, you know, who is your community? Is it the BMC cancer patient population? And have you thought about ways to engage them? It sounds like you're doing some great work at and engaging them to be part of studies.
Yeah, no, exactly. I think that's probably sort of where we're at. I think the way you described it is exactly right. Our engagement, or our community are our patients. And that was really where we needed to start. And I guess in terms of engagement, if you think about it in that context, one of the barriers was sort of a perception that research is separate from getting great clinical care, and that these are two completely separate things. And what we tried to do is really convey the message that these two things are so intertwined. To really be providing great care, it's actually a real advantage to also be involved in research, because that's where you're developing the next great ideas. And it comes to how we're talking to the patients and getting the informed consent. And one thing that we have really tried to do is make sure that those discussions are happening together with the patient's providers. And I think that has really helped in terms of conveying the message, in terms of some of the trust. But it can also be a real challenge. And these, we saw these are some pretty complex questions. And when you're trying to do it through an interpreter, for example, or explain to someone who may not have a high scientific background, those are some, it takes a lot of time and it takes a lot of effort. It's critically important, but I think those are some of the challenges that we're seeing.
So what I heard you say is that you've had some successes in enrollment, and the two areas that allowed you that success were really sort of messaging that research is good care. And the second is engaging other stakeholders, including their providers. And both of those things get at sort of the underlying mistrust of sort of, the research sort of enterprise. And so I wonder how you got to that space to problem solve. Did you get input from patients? Was it just experience with interacting with patients that maybe sort of led you to sort of those solutions?
Yeah, I think any patient is going to want to hear from their provider. You have that close relationship, you have that element of trust, no matter who you are, I think. And I think, tying in these questions with that relationship is important. I would say it's not just about the patients, it's also about convincing the providers that research is important too. So it's really on both sides there.
Mm-hmm.
For us, what was eye-opening was, we would develop, we iteratively we'll develop some intervention content and then bring it to patients and to providers as well. And we think it's like the best thing ever. And then when we bring it to them, they're like, no, this is, not what, what we were thinking of or what would we be satisfied with. And so I think Matt, what you're getting at is that like it requires great agility on the researcher's part to be adaptable, because at the end of the day, you can create the best program at your desk, but if no one uses it, it's 0% effective, right?
Mm-hmm.
So we've been surprised and humbled by our results. Our text message program is to improve the oral health of young kids in federally qualified clinics. So the text messages go to the parents. So our stakeholders were a variety of clinics, community health centers, as well as the patients and, parents of young children. So we had to consider both of those stakeholders when designing not only the content, we'd show them text messages, but also the entire structure of the program. And so that also speaks to what Matt said, like we had higher engagement rates than most text message programs we've seen in the literature. And I think it was because of those years spent, designing and co-developing the program.
That's amazing. Your remarks just sort of touched on a lot of what we presented earlier around sort of the competencies of being community engaged in your approach, and just sort of having the openness, introspection, and respect for your stakeholders and what they bring in terms of their experiences. And so can you talk a little bit more about how you identify like who to bring it to? Do you have like a longitudinal or like set group of providers or patients that you bring things to, or do you recruit individually for different projects?
I would say, different projects require different, populations and providers. So for the one I just talked about, was funded by the NIH, and we were in 4 different clinics, one at BMC, Dorchester, South End Community Health Center, and Codman Square. So yeah, our providers were already identified, and building the relationships with the individual providers in the group as well. Like we would do presentations at their, their provider meetings, and make sure that we were communicating and not disrupting their workflow, and telling them everything that was going on, and hearing from them like, how is project implementation going? So it's good communication, like from the start, helping them, them helping us design the program, but even after implementation, and then after the study's over, like we're going to go back and present our findings to them as well. So
that's great. Do you have any examples of sort of collaborating on dissemination with community members, whether they're sort of co-authors on papers, or whether they sort of help you identify audiences for the information, or help you even develop the messaging?
Yeah, so I think when we were working with those groups, we definitely kind of use the snowball technique, where they recommend other community members to be part of our focus groups and interviews. And it was really important not only to do, focus groups and interviews, but also have them use the program for a little while and give us feedback. And we would then design and develop a little bit more, and then they would use the program again, and then have us design and develop a little bit more. So they were kind of like partners the whole way. It wasn't like we had focus groups and then we just designed. They saw like every iteration through the program. Yeah. And then some people use a model of, different, as you probably know, different people, different community members for different focus groups. And some people have like, a true set of advisory board members. So Lisa can speak more to that, where you have kind of a constant set of members that you're going back to, and mine was kind of fluctuating. So.
And maybe Lisa, you could tell us, thank you, Belinda, tell us a little bit more about the community groups that you engage with, because you're fortunate enough to work with a long-established group who are focused specifically around the health of those who live within public housing. Maybe you could tell folks about some of those successes.
Sure, that I'd be happy to. So beyond, as Belinda was saying, like beyond the development of the project, just in our advisory board meeting we're having at the end of June, one of the main topics of conversation is how to start disseminating this information to all the other residents who didn't get enrolled in the project itself. Like, how are we going to go about doing this? One of the things we're going to start off that conversation with is showing the posters we designed in our pilot study that we hung up around the developments after the study was over. It included links, and it had a web version and resources and tear off pads. So we're going to start off the conversation with an example and then see what people think and what should we do for this project, because obviously not everyone can be included, and some people went to the control group and didn't get an intervention. So we want to design something So this is one of our ways we'll be engaging with our advisory board in the future.
Excellent.
We're hoping to disseminate our program to other community health clinics across the country. So we are interviewing the providers at the community health clinics that we're working with to see how we can best do that. That's
a great example of using your stakeholders for their, for the expertise that they bring. And I appreciate, the description of how you identify who the stakeholders are. And I think that's an important part of from community engagement perspective. A lot of times people who don't have experience with community engagement think, oh, that means I have to engage with the community, a member in the community of the population that I'm trying to help. And that's not necessarily true. It's really about, and that's why team science is so aligned with community engagement. It's about, who are the stakeholders who have the expertise to solve the problem. And that solving the problem is scientifically, right? Like who has the scientific expertise needed to solve the problem. But the other set of stakeholders that are required are those who understand the problem from the perspective of who's going to use it. So providers are often a really important stakeholder, as well as the patients, community members, family members. And so I think the process that you've described of sort of identifying both of your arcs have sort of identified who's necessary to solve the problem is really a strong example of, how you create multidisciplinary teams that engage diverse groups. So we have only a few minutes remaining. I don't see any questions coming in on the chat, but I welcome people to please throw them in there if they have any, or raise your hand. We haven't talked about real challenges of doing community engaged work within your arcs and within your projects. And it's very valuable for us as the CE program to hear about the challenges that you're having so that we can help support programs and solutions to sort of overcome them, because your problems are likely not unique to your own work. And so I wonder if you could speak to, Matt, the challenges of even getting started with engaging the community in the work that you're doing, or, Belinda and Lisa, any sort of examples along the way that really have tripped you up and that continue to be a problem.
I'm sorry, we talk about our community, but in fact, we have so many different communities that we're serving, and they're all coming with different cultural perspectives about research, which it's got to be about the coolest thing to be involved in, but it's also extraordinarily challenging. And I guess maybe the one relatively common theme perhaps is that I think a lot of patients come to us certainly not really expecting to be involved in research. So there is a gap, and I think communicating that out, that BMC really does more than just provide care. And as I was saying before, providing really high level care does mean being involved in research, and those two things go together. And the challenge and question would be how to sort of message that out to the many different communities that we serve.
So I just to sort of follow up on those comments, I'm sorry, I'm apologizing for my dog who's starting to make noise. And so I'm trying to censor her from you. And I lost my train of thought. So Belinda, go ahead and I'll think about what I was going to say.
Yes, so I was going to talk about a challenge that we've been having. So our project this year is to develop this digital health inequity checklist. So we want to create a checklist for researchers and developers to follow when creating and testing digital health technologies to ensure equity for all users. And the problem that we're having is very much akin to what Matt was saying, is that how do you create a checklist for so many different cultural groups and groups with disabilities and make it sort of relevant for all. So that's kind of what we're up against. I mean, there's some overarching issues like health literacy and user engagement and general accessibility, but then there's things that are like specific to each sort of underrepresented group that would need to be in these guidelines. And so that's a big challenge for us. How to tailor it, but also make it widely applicable.
Sorry about that.
That's okay.
I remember my thought back to Matt's comment, which is the issue in community engagement of, having specific community members who are supposed to represent diverse community. And that's a challenge in all of the work that we do. And that, there's, we can't make assumptions that a small group of people represent sort of the whole group. But, acknowledging that and understanding that is a step forward. And so the fact that you acknowledge it as a barrier, I think is really important. And when we do engage partners, we can not expect them to be able to represent all of our, communities. So I'm hearing some common themes from this group about a lot of great successes that you've had in developing your ARCs. And it highlights for me how many lessons we learned from team science inform community engagement and vice versa. And so we heard about, defining a complex problem and identifying who needs to be at the table to help find the solutions. And we heard about different approaches to identifying those people. And some suggested venues to be able to bring people in. We heard techniques of sort of snowballing from your community partners to identify new partners. We heard the need to identify different community members for different projects because of the nature of the work that you're doing. And we heard about some challenges of having representation for all populations. And so we're closing out the last 5 minutes of our time together, and I want to see if our panelists have any closing remarks or comments that they'd like to make. Or anyone.
Dr. Katya Ravid wrote an excellent article that describes team science and the ARCs. So maybe we can send that around.
Oh yeah.
She wrote it about 8 years ago or so. And it's really helpful for everyone to read, but particularly if you're interested in applying for a pre-ARC.
It's great advice. We can definitely get that out to this group. Any parting remarks from anyone else on the call? Any of our members who are here with us this evening, the community engagement team or our guests? Thanks, Robin.
Just a wonderful session. I really take away this, the way that you built your ARCs are similar to how we build community partnerships. And so as Tracy mentioned, just so many ways to, so many things that we're learning from each other. So thanks.
Yeah, and if anybody's interested in, joining an ARC, reach out.
Excellent. Well, we're going to end here. Thank our panelists for their wisdom and insights and their time. Happy Juneteenth to all of you who are able to celebrate and take some time to reflect. And good luck to the Celtics tonight. And Dima wants us so we want to thank you for joining us for the last of our series. Please sign up to be part of our listserv so that we can tell you about our programming for next academic year, which will be rolling out in September. Thanks, everyone.
Thanks,
Thank
Tracy.
you.
Thank you.
Great night.
You too.